welcome to this webinar. Um, I would like to start by emphasizing that Ceribell EEG is like any other EEG. It is recording electrical activity from the scalp. So it's an FDA-approved EEG machine, and it does what any other EEG machine supposed to do. With the headband going around the head in a circumferential montage, it collects electrical activity across the transverse of the brain with 10 electrodes. So the reading of the EEG is going to be different than the conventional EEG reading, since this is going to include only 8 channels. As you will hear later, every channel of EEG is basically the electrical potential that is collected between 2 electrodes. So the potential, the difference between electrical field in 1 versus 2 will give rise to 1 channel of 1 line of EEG. So you will see 4 on the left and 4 on the right. As you see, this is not the 16 plus type of channels of EEG for a given reason. It was designed as such. It wasn't because we couldn't put more electrodes. Putting more electrodes is not a big deal. We designed it this way because, as we have shown in multiple publications, this particular montage is perfect for differentiating or basically stratifying your action on a given patient you have been consulted on as a neurologist, neuropractitioner. If a patient has been consulted and you're requesting EEG, it's most often because the patient has what we call it altered mental status. And this particular setting of EEG allows the user within 2 to 5 minutes to stratify their action. And the EEG course that we have planned is basically inspired by the idea that we are not going to be counting trees or describing fancy terminologies for you to read the EEG with, but we are describing a way of thinking so that you can read the EEG to stratify your actions in at least 3 ways. The EEG should be read. The Ceribell EEG is meant to be read as either normal or slow in blue, or highly epileptiform pattern in orange, or seizure, or status epilepticus, which is a continuous seizure over 5 minutes. And as you see, the size of these circles is different because majority of times, if you have 100 EEGs, majority of these EEGs, no matter what population you are actually testing, it's more statistically likely that the EEG is going to just show diffuse slowing or focal slowing or maybe normal. And probably 10 to 15% of the times, it's going to show highly epileptiform patterns, which basically means this particular EEG contains a lot of epileptiform activity that's usually seen in an epileptic brain, meaning spike and wave, sharp wave and slow waves, etc., that you will hear more about during the presentation. And only in the minority of cases, you're going to be seeing seizures. By doing so, okay, what happens and how your action will be stratified? If it's normal or slow, basically it means this is not the time to escalate anti-seizure medications or intubate the patient being too over-aggressive. And believe it or not, because majority of EEGs will fall in this domain, this is perfect way of preventing over-treatment, aggressive over-treatment, and helping the patient. because these overtreatments can be sedating and so on. And you can decide how long you want to actually continue recording before you say, okay, this is fine and it's enough. Studies have shown that if you do about 4 hours of Ceribell EEG, and it is perfectly void of any epileptiform activity, given that the patient is not epileptic or didn't just have a convulsion, it's going to be safe for the patient. Not basically, the patient's risk for having seizure in the next 24 hours will be minimal. And then the highly epileptiform patterns will, if you see these, it will stratify your action, because then it means this patient is at higher risk for seizures, and you better give the patient anti-seizure medications. For example, a nice dose of levetiracetam, and consider continuing recording. And these patients are at higher risk for seizures. And of course, patients who have seizures on their EEGs, reading the Ceribell as such will basically stratify the action towards being aggressive in your treatment and making sure that you use the Ceribell recording to verify that you stop the seizure. So I urge every one of you to think about these 3 ways that you will be reading EEG. Either it is normal or slow, or highly epileptiform patterns, or it is seizure. And as you will see in this course on EEG, we will refrain from using sophisticated terminologies that have unfortunately often served as source of confusion rather than source of help. An EEG reads something and writes a very lengthy procedure note that may not be of use for an ICUer because it doesn't really guide the ICUer in terms of what to do. But we hope that Ceribell procedure note will be short and concise, and it will basically aim at stratifying actions in these 3 possible domains. And because of that, we designed the electrodes to be fast and sleek and easy to use, because you're not going to have the luxury of depending on an EEG tech to put these electrodes for you in the middle of the night. It will be a nurse who has perhaps never set up an EEG. And that's why it has 10 electrodes rather than 16 plus. We have published extensively on this, and for those of you who can take a screenshot, these 3 papers summarize the evidence, including the last one from MGH, showing that basically the yield of finding pathological abnormalities is very like the yield of conventional EEG. And I want to emphasize that Ceribell EEG is not used to diagnose someone with epilepsy and decide which side of the brain they need to be, we need to cut to treat the patient's epilepsy. This is not for source localization, but it is for action stratification. So please think about these 3 possibilities, and I'm going to transition to the recorded panel discussion that I had with John Stern this morning. I'm here. Please write your questions, and we will answer those in the chat. And afterwards, we can also have open Q&A if you would like to have your voice be heard. Dr. John Stern, as many of you know, has authored several EEG atlases and is very well known in the domain of EEG interpretation. I hope that you will enjoy this conversation that I've had with him, and you will see we have some tricks to teach you as to how to read Ceribell EEG. Thank you.
Thank you, Dr. Parvizi. It's really a pleasure to be here. And I see my task is to bring those of you who are watching into the conversation to understand some of the basics of EEG, to make the use of Ceribell or any EEG a little bit more natural. As Dr. Parvizi said, the Ceribell is an EEG. However, the use of Ceribell goes a different direction than the use of EEG as a whole, because it's intended for quick decision-making in an acute care situation. The setup is such that allows for quick attachment of the electrodes, and this is what you see in front of you here, that the 10 electrodes are all in one band. pre-configured, so there's no measurement or layout, which typically requires a technologist. And they're wrapped around the head with a placement according to landmarks, but then the electrodes are conventional electrodes. The point I want to take here, and as we build up the understanding as to what the EEG is that each of these electrodes essentially makes a connection to the scalp and has to close a circuit. And what I'm going to describe now is all basic high school physics to make this intelligible. But closing a circuit with metal across the skin requires some conductive material, and that's preloaded in the assembly you see in front of you. It's a little bit of gel that allows for connection to be made, and this gel has to get make a good attachment to the skin, which also requires some cleaning of the skin. And so the setup allows for some debridement of the superficial layer, which is usually done with a separate device by a technologist, and then placement of gel and an electrode across this. So by closing the circuit and including the skin with the recording wire, it's the entire EEG, one has a way of sampling the electrical field around the scalp. Can we go to the next slide? This slide is helpful for some understanding as to what the EEG is, but it also is useful for some thought about what it's not. You can see the EEG is generated by neurons, and it's predominantly the pyramidal cells in layer 5. And the electrical field that's generated on the scalp comes from a confluence of such neurons. So it's not one neuron generating one region. These are not potentials from the firing of one cell, but EEG really is the combination of many neurons together collectively, maybe 3 to 5 square centimeters. And this is important going forward, and we get back to some of the basics of reading EEG, that we're not looking at one small region of the brain, we're looking at large regions of the brain. However, despite the anatomic coarseness, EEG is really helpful because it provides great precision to temporal change, the fluctuation of the brain, but also provides, and this is where we're really going to be heading, details of that change, the waves, in other words, that are meaningful. The other part of this slide that's important, but also could be misleading, is that we're not sampling the electrical field at one spot and then we're sampling the electrical field at another spot. You can see 2 spots being sampled here from 2 different neurons. But these samples are really electrical field. And you might remember from high school that if you take an electrical field at one location and compare it to another electrical field, you get a potential difference. Potential at 2 locations can differ. And when you have a potential difference, that is a voltage. And that's the output of the EEG. It's the output, of course, for any electrophysiologic monitoring. The difference here is that with the EEG, the electrical fields are so small that we have to be looking at 2 locations and comparing in order to see a signal of meaning. We can't compare the location of one neuron or one field here to some neutral reference and see how it's changing, because there's so much noise in the environment. And this is a fundamental aspect of EEG, that we're always comparing 2 locations. Next slide, please. The other fundamental is that we're looking at really shape as well as frequency and amplitude. So often when people begin looking at EEGs, they're thinking about the frequencies that are present, the oscillations of the waves, or how high amplitude they are in comparing, and think about this as some type of oscillation signal. But the shape of the wave is important. This is a tricky part as people begin learning to read EEG, because one has to get a sense of what these shapes look like. The shape you see in front of you here probably looks a lot like the ECG or the EKG, and it's true, it is. And this is the fundamental shape for a membrane discharge. You have a depolarization and a repolarization. And that's what we see in some times on the EEG, but in particular, during times that there is a coalescing or synchronization of activity. This shape, which sometimes is called triphasic because of the 3 phases, is a marker of a discharge that is assembled from a large region and is indicative of something that's epileptiform. So I'm going to say epileptiform to point out that this shape has relationship to epilepsy, but it's not necessarily epilepsy. It's the shape of something epilepsy. And this is another part we're going to get back to as we're looking at EEG, that the EEG is something that's used in the context of a patient. And the diagnosis ultimately is the synthesis of what one sees on the EEG to what is happening before your eyes for the patient. But I'm going to point out, I'm sorry to go back the slide, the three phases that are important to keep in mind going forward are the sharp upward slope, the sharp downward slope, and the rounded after slope. And so we think about that as being part of the spike and then the slower wave. You may hear the term spike and slow wave related to epilepsy, and it's just this three-phase waveform. Next slide, please. I said earlier that we're sampling across the scalp. This is a schema for an arrangement of that sampling where we compare the electrical field at the electrode that's just to the right of midnight on this cartoon. It's labeled FP2, to the electrode just clockwise down from that, which is labeled F8. And there's an output signal. And so any output signal of EEG is the comparison of two locations, which is why with Ceribell, although there are 10 electrodes, there are 8 output channels. One has 5 electrodes on each side of the scalp, and that generates 4 output channels. Here we can see 3 output channels coming from 4 electrodes. And you can also see that the circle or the oval that includes the F8 and T4 electrodes produces an output that's flat. Well, that oval is intended to indicate that the electrical field of those 2 electrodes is the same. And so you subtract anything from something of similar value or equal value, really, you get 0 in simple math. And so the output here is flat, but that doesn't mean there's no signal there. It has to do with the amplitude present on the scalp. And that's an important lesson here because sometimes people get misled by amplitude. Amplitude has to do with the change in electrical field across the scalp. And you can have a very high amplitude at F8 and T4. Electrical fields can be very high at these 2 locations. But if they're the same, then the output in the EEG is flat. And so that can mislead you to think that it's nothing there when in fact there is. The other element, which is less important for the decision-making we're going to be learning about today, is to do with the direction of the signal on the EEG. You can see it's pointing down in the first channel, which is FP2, F8, pointing up in the last, which is T4, T6. It has to do with whether comparing these is going from larger to smaller or smaller to larger. It becomes part of the detailed analysis of EEG that is maybe more of a study of the trees, as Dr. Parvizi put it, and maybe less important for the decision-making that one needs to be considering in the acute use of EEG. I think one point that you're going to hear repeatedly during this educational session is that use of EEG should not be restrained by getting deep into the details of the EEG, but EEG needs to be used in a way to allow for quick and accurate decisions for patient care. And understanding some of the fundamentals that I've described here can be helpful, but should not be in the way of the decision-making. So ultimately, better decision-making can come from understanding the fundamentals, but the idea is the democratization of EEG is the purpose here. Thank you. So this tracing with EEG includes 8 channels. You see on the left side, channels 1 through 4, which are labeled for the first 5 contacts. And the right side of the head, electrodes 6 through 10. And so it's an outlay or the representation of the surface of the head going across the lateral aspects of the head, first the left hemisphere, then the right hemisphere, going from the anterior to the posterior. And I think what might probably be catching your eye first is the very fast activity, the jagged activity across the right in the first half or so of the recording. You can faintly see dotted lines that are vertical through the entire page. These are indicators of 1 second. And so you get a sense that these jagged lines are actually high frequency because there are too many for me to count within any 1 second period. This is actually artifact. Our eyes might go to that first because it looks rather nasty and fast and maybe angry, but this is benign. This is artifact from muscle contractions because the potentials from muscle are much faster than the potentials that we record from the brain at the scalp level. Of course, there are faster potentials if you record intracranially, but that's what we're talking about here. On the other side of the head, on the left side, you see a discharge standing out. And it has somewhat of that shape that I described before, that triphasic or epileptiform shape. And there's a sharp component and an aftergoing slow component. And it's that shape that's meaningful. And this is another area of EEG that trips people up initially. When people look at amplitude and frequency, but they're not thinking so much about shape. And ultimately what makes a good EEGer, electroencephalographer, is seeing those shapes standing out among lots of chaotic or disorganized activity. It's looking for something neat and distinct that has a familiarity. This shape indicates something that's epileptiform, and this indicates an area of electrical irritation, in this case in the left anterior temporal lobe based upon the labels. But this is not a seizure. This is an area of electrical abnormality that indicates a predisposition to seizures, but this is not something you would treat as an acute emergency. And it's important to keep this in mind as we go forward. Next slide. You can see here a very flat EEG, and then a burst of activities, and then more flat activity. And this is a burst suppression pattern, a burst of activity, and then very low amplitude activity. This is not normal, but this is not specific for one type of abnormality in terms of the burst and suppression. Beyond the burst and suppression, the inconsistency of the amplitude, one sees within the burst spikes recurring, and a spike is a short duration wave with some aftergoing slow wave. And so this is a burst of epileptiform abnormality. And this can be due to severe cerebral injury, and it also could be part of status epilepticus, or it could be both. But it's seeing the shape of the waves within that burst, which makes this section of EEG particularly worrisome. The burst by itself with suppression, it could just be an effect of anesthesia. The person have to be under anesthesia. And of course, anesthesia is reversible. So it's not necessarily a critical abnormality, but it's the shape of the waves within this that bring my eyes to this being something needing clinical attention. Next slide.
When do you start getting worried about burst suppression, and when do you think patient is going into status?
So part of this, the answer is going to be one of experience and time, and part of it is going to be a matter of trying to approach it more simply. I think the simpler way of going about it is looking for some consistency within the burst. If you're seeing the same wave recur, the same shape recur within the burst several times, and I see it here, the similarity of 5 or maybe you can say 6 times a similar shaped wave is occurring, that raises my concern that this is an abnormality that's epileptiform. And so seeing something that repeats is the concerning part. I think to maybe bring this to some people who are new to EEG, we can use the analogy to the EKG, that when you see in the EKG the same QRS complex over and over again, and that complex has the shape that's familiar to you, that's relaxing, that's relieving. When the complex varies each time, that raises concern for an arrhythmia of the heart.
How about the
opposite for the EEG?
How about the depth of burst suppression itself? I usually like to see if I'm looking at 15 seconds or 10 seconds. Here I see 15 seconds, and I see that the burst is 5 seconds of 15. So I say 5 divided by 15, basically 1/3 is burst, 2/3 is suppressed. Is that correct? And then
I think that's a marker. It's a way of nicely and straightforwardly quantifying the severity of the cerebral abnormality. It doesn't go along necessarily whether it's a seizure or not, but it goes along with the gravity of the cerebral dysfunction. And that's useful going forward for following up and seeing whether the patient is worsening or improving in terms of that cerebral dysfunction. Yeah. You see across this section a recurring wave that's more separated. You're not seeing the suppressions that we saw before. You see across the right side that there's continuation of a relatively preserved frequency, maybe 10 hertz or so. That doesn't really matter, but because it's within the normal range and consistent. But on the left side, the top part, you see a wave recurring 6 times. And you can see the similarity of that discharge with each occurrence. It's like a spike and a slow wave. There's some other activity riding upon it, which is less consistent. But the shape of this indicates it's epileptiform. And the recurrence of it over a short period of time goes along with what's called periodic. And the periodicity, you might say, is about 1.5 seconds, or the period. But what makes it periodic is not just that fixed interval, but also the similarity in shape. And this type of discharge is also epileptic form, but this type of discharge is more common somebody who has a subacute cerebral injury and is at greater risk for a seizure than a person who has one discharge, or even 6 discharges randomly scattered over 20 minutes. Here we have 6 discharges time locked over 10 seconds. And that timing of the discharges is what raises concern and leads to greater need to keep an eye on the patient for progression into a seizure. Yeah. The prior section had the periodic discharges across one side of the head. Here you can see they're across both sides of the head. Generalized is the term that's being used now. One point called bilateral. But you can see that they're time locked on both sides. The discharges are different than you saw before. They're shorter duration spikes. And this is the important part, that it's the similarity of each discharge that makes it concerning and attention grabbing to me. It's not that a certain duration has to be met. They're not measurements that indicate one type of versus another. It's the stereotype nature of it. You can see 5 of them across this page. The interval is not as fixed as the other, but that's okay. It's the relative preservation of the interval and the relative preservation of the shape that makes it concerning. Jeep heads, as they're sometimes called, occur with diffuse injury, anoxic injury, for example, and can be a sign of poor prognosis, but they also can be a sign of seizures. And this is one element of making the decision. The action item part of the Ceribell is paying attention to the frequency of these discharges, which I think we'll get back to a little bit later. Next slide. We see here part of a seizure. And I think a tricky part of identifying seizures is trying to identify them over a short time window. I mean, it's almost behaviorally. If you saw a person having a seizure, but you only saw 5 seconds of the behavior, it might be hard to say whether it's the seizure or not. And the same thing is true for EEG. And so looking at 10 seconds, 30 seconds increases the accuracy. What I see here across the left side is a poly spike. I see several spikes followed by slow. And I see them occurring over the entire period of time. I see them pretty close together in time. And I'm wondering how they're going to change over the next 10 seconds or 20 seconds. But it's that progression and consolidation of the abnormality, of the epileptic abnormality, that raises concern that this is a seizure. This is an asymmetric seizure. This is a focal seizure, in other words. Although you see some features of it on the other side, it's predominantly across the left. And in fact, it looks more confined to the left posterior region, contacts around T5, as you see here.
Yeah, John, what you mentioned, poly spikes for the audience, you were referring to these multiple spikes followed by a slow wave, correct? Sometimes
that's right. Yeah.
Spike followed by the slow wave. So this basically, if you see only the slow wave without these, you may not perhaps worry, but having this 3 phases of one spike followed by a big slow wave, that's what you were referring to.
That's right. So the canonical shape of the spike and slow wave has a variation where you have 2 spikes or 3 spikes leading into the slow wave. And it has the same clinical significance, even if the shape is a bit different.
And I also, John, I don't know what you think, but when I teach our fellows, I usually say, think about a big hollow space, and then you're putting electrodes over the ball, like a ball sphere. These EEG electrodes are not necessarily just recording activity underneath the electrode themselves, but it's actually just the average of the whole sphere collected best from that point of view. So would you say that explains why you're seeing this type of activity on the other side of the brain, even though you don't have seizure on both sides? Primarily, you're basically hearing the explosions on the left, especially the posterior channels, from the right side as well.
Yeah, exactly. So one doesn't have that anatomic precision of the EEG. You're looking very broadly, and that's okay, as long as you know what you're doing.
Yeah, this is very important because in discussions when we talk about parasagittal and midline seizures, if something is a seizure, usually it will create such a big field that you will be hearing the explosions from elsewhere as well. So it's never like remaining precisely very, very focal. If it remains extremely focal, it may not have the big energy to generalize to other sides of the brain or other areas of the brain. And usually those are not the ones that cause severe altered mental status. Would you agree?
Yeah, to that point, you bring us to a really important clinical pearl, which is when you see something on EEG at only one electrode, be very suspicious that it's artifact or noise, because cerebral degenerative activity should not appear at only one electrode.
Right.
There's exceptions, but that's a good place to start when you see that.
Yeah. Which we read, when we read EEG, we say, hey, look at this, it has a field. So what it means is that what you are saying, John, is that if you had seen only in this particular electrode and not in the neighboring, more likely it's an artifact, because this particular activity is a potential between 3 and 4. So if it's happening around 3 and 4, certainly it's happening around 4, and therefore it should be affecting 4 and 5, and it should affect 3, which would affect the potential in 2 and 3 potential. So that's why it has a field in the adjacent channels.
That's right.
Thank you for highlighting that, Dr. Stern.
Here we see a seizure that's progressing more quickly. You see how it starts off as one discharge in this first second, skips a second, you see another, and then it builds and it changes. And that's another feature of focal seizures in particular, this change over time. And by time, I mean 10 seconds, 30 seconds, that time scale. And the change is a matter of the frequency, the shape, the distribution across the scalp, but it's that progression or evolution that corresponds to, in fact, what's happening behaviorally with the seizure manifesting in different aspects across the seizure occurrence. And so watching for this change is helpful. But the features of change are discernible. They're clear. We have an idea of what they are. And this, of course, is helpful for quantitative methods, computational methods, to identify seizures through artificial intelligence.
So can you comment on why we don't see that very typical sharp and slow wave that happens in the beginning? It kind of becomes so crowded that it gets kind of mixed. You don't see that a very sharp and slow.
Yeah. So the sharp and slow wave, or spike and slow wave, it's also called, just so everyone knows we're talking about the same thing, is not one phenomenon. It's an abnormal discharge, but the slow wave relates to a correction for that discharge. And the slow wave actually might be the response to the abnormality, normalization. As a seizure begins, a focal seizure in particular, one loses that correction. It becomes a sequence of discharges. And so it becomes a rhythm of clean, well-formed spikes or sharp waves at one location that end up picking up and spreading. And maybe it's the loss of the slow wave which allows for this to happen.
Would you call this an evolution?
Yes, evolution is a commonly used term for it.
So if a rhythm has an evolution, if a rhythm is evolving in frequency or in space, more likely it is a seizure.
Yeah, I mean, I think of the 4 elements of evolution. One is the distribution of the space, another is the frequency, another is the amplitude, and another is the shape. And you don't expect necessarily all 4 to show evolution during a focal seizure, but you expect at least 2. If you see 1, maybe be suspicious. If you see 4, you've struck gold. But 2 or 3 are most common, is what might change. And here I'm seeing a change in distribution. It's becoming more broad. I'm seeing a change in amplitude, and I'm seeing a change in frequency. It's getting a little faster as it goes across the page.
Right. Maybe on the next page, we would see that other channels neighboring channels are also being affected, and that would qualify as evolution in space. Great.
Go to the next.
Another example.
This is bilateral. These are really clearly formed spike and slow waves. This isn't the same type of pattern of a seizure as we saw on the prior slide, because the sharp waves are farther apart. There's a slow wave still there, but they're continuous and they're occurring very close together in time. And this is more of what's called a generalized seizure. Generalized seizures may have the slow wave still present, but there's no clear normal activity between the spike and slow waves. And so it becomes a succession of these discharges, which if they occurred at one time would be interictal or between seizures, but because of their linking of one to the next, become an ongoing state of seizures, a status epilepticus. Knowing how this changes over time is still useful, but looking at this page would be very concerning that I'm seeing only epileptiform abnormality.
I would also comment that on this EEG, you're not seeing artifacts of convulsion, the muscle artifact or movement artifact. So most likely this is the case of non-convulsive status epilepticus. Would you agree? Yeah,
so true. And that's a really important point because people often think about a seizure on an EEG is going to look crazy, chaotic, disorganized. And this actually looked quite clean. It almost looks like an EKG. But this is an EEG of severe cerebral dysfunction. And I would expect this person, can't know without seeing them, I expect this person to have real impairments, be unresponsive, and be staring off. And the fact that the person is staring off emotionless is why one's not seeing the artifact of a convulsion.
So also to differentiate between this pattern and GPDs or GPADs, John, would you agree that in this case, of course, we are not seeing the preceding phases. There was clearly an evolution of waveforms that brought us to this page that we are showing. But just by looking at this page, of course, some EEGers are well known to have inter-rater variability, very significant ones. So one person may call this GPADs and another person may call it status. Would you like to comment on the frequency of these waveforms and when it becomes toxic to the brain, and when should we start treating the patients regardless of what we call it?
Yeah, so you're speaking to a gray area between interictal or between seizure abnormality and seizures. And part of the answer to your question is we've discovered over the past decade or so that the frequency of these discharges matters, that when they're faster than 2 hertz, particularly if they're faster than 2.5 hertz, they're likely to respond to treatment with recovery of the patient. But when they occur more slowly, maybe 1 per second, they're more likely to be related to more of a structural change that will not respond to treatment overall. But the other part of this is that netherworld between a seizure or status epilepticus and something that's not a seizure. And that goes to this inter-rater reliability question that different EEGers may see the same thing differently, have different thresholds for abnormality. And that gray area is a problem in EEG. And it becomes an obstacle to people learning EEG because they feel like, there's this sense of uncertainty built into it.
Right.
But I wouldn't want that uncertainty or that gray area to interfere with decision-making for patient care. And at a certain point, there has to be a consensus as to when to act and when not to act, and guidance for that in order to bring the EEG into a useful, real-time treatment decision aid.
Right. So for someone who has not seen this EEG evolving into this pattern, and we call it status because we have seen the EEG before this page. But even if you want to call this generalized periodic discharges, because there are 3 of them per unit of time, this definitely is a case that needs to be treated regardless of what we call it. Great. How's that different from normal, Dr. Stern?
So one pithy response is there are many ways of being normal. There are only a few ways of being abnormal, at least in EEG, maybe for everything. And so very often, if you're not seeing a clear abnormality, you might want to just call it normal. But what you show in front of here is a boringly normal EEG. Not that normal is so boring, but I'm seeing frequencies and symmetry that I know are normal, and I'm seeing some variation in that across the page. And what I'm not seeing is the epileptiform abnormality. And so I think when looking at EEG, one way to go about this is to first make sure you're not seeing noise, and then if you're not, look for patterns that are more likely to be epileptic form, with the idea that if it's not that, it might just be normal. And so it's easier to go that direction and go the other.
Would you comment on this waveform in the back of the head, usually around here and here, or in this channel?
Yeah.
Between 8 and 12 of these waveforms per unit of time.
So this is the posterior dominant rhythm, also called the alpha rhythm. It's called the alpha rhythm because it was the first rhythm to be discovered in the early days of EEG, the 1920s. So first on the block, alpha. But it's present as a normal finding in the vast majority of people. A person who doesn't have it can still be normal, but the vast majority of people do have it in an awake state and a relaxed state. A person who's tense or visually inspecting an area because will not have it, and that's normal. It's present with the eyes closed. And if you go to the left side of this, the third second from the end, you can see a change to the alpha rhythm. Maybe you can circle that for just to the left on the left side. Yeah, I was thinking of the second before that. And that change I consider normal, not just noise also. And that's nothing of particular meaning because it's only present at the T5 electrode. That only channels that have T5 have it. And so probably something just knocked against the T5 electrode at that moment. And using that as an example of a change to the EEG that does not have a credible field.
So is it fair to say that looking at the EEG, you can think about basically the horizon in the ocean, not too many drastic departures from baseline. It's kind of quiet. And you see in the back of the head, this rhythm that is beautifully sinusoidal shape type of rhythm in the 8 to 12 hertz. You know that state of the union in this particular brain is fine.
Correct.
Compared to here, Doctor.
So obviously this one shows slower frequencies. And slower frequencies are not necessarily abnormal because slowing like this can be seen during sleep. And the slowing of sleep is like this, that there's a mixture of frequencies. You're not seeing the same duration wave across the page. They're varying. They're varying within a narrow range of maybe between 1 and 4 hertz. You see some long ones and then some shorter ones where you see like 4 within a second. But notice something else. There's an asymmetry. You're seeing a greater amount of slowing across the left side of the head compared to the same periods in time on the right side. And this amount of asymmetry is abnormal. And this is indicative of some type of functional, it could be structural, cerebral dysfunction across the left side. Can't say exactly where it is precisely because it's EEG, not MRI. But the level of asymmetry is concerning. If we saw that in the next second, it was
you will have better focal slowing here, Doctor.
Yeah. Then it might be a shifting asymmetry, but the prior one showed an asymmetry to it. And so the slowing is not a sign of a seizure. So slowing is maybe a sign for a scan to understand why the slowing is present, but wouldn't warrant a change in treatment.
Yeah, this pattern.
Yeah, go ahead.
So the focal slowing on the right side could be either because somebody just had a seizure on the right side that knocked out the hemisphere, the postictal state, in other words, or it could be that the patient is having some ischemic event on the right side, correct? That you're not getting enough blood for the brain cells to generate these beautiful rhythms, and therefore they are going slower. Yeah,
or it could be a tumor, or it can be an infection. So the non-specific disturbance in function, which can have a structural cause, you can't say from the EEG.
Fantastic. Great. Wonderful. Thank you so much, Dr. Stern. But quickly going over some of the patterns that I think our new readers should be aware of. First of all, as Dr. Stern said, pay attention to left and right. Always see that the left is over the right channels. You will have 4 and 4. And sometimes pathologies can be confined to only one side of the brain, as you saw in the preceding slide. And then there are certain parameters or certain tools that you have at your disposition to use, and that will definitely change the morphology of the waveforms that are displayed on the screen. One is really how you are compacting the EEG. So here, 10 seconds of EEG per page will be shown. So each of these horizontal lines demarcate a second. So if you actually compact the EEG to like 20 seconds per page, everything will start looking sharper. And that's not a nice thing to do. Usually I read it at 10 or 15 seconds per page. And then the second thing is the scaling of the waves. So this scaling means how much basically of the ink you are using per millimeter of space. In conventional EEG machines, they have just followed the same trend from the time of paper and ink. When we had EEGs on paper, we had only one size of paper, and the ink, of course, the pen knew how much to go up and down based on how many millivolts it was recording. But when you are dealing with iPhone size screen versus a plasma TV size screen, then calibration of waveforms in microvolt per millimeter of that screen will be very problematic. So at Ceribell, this problem has been solved by basically giving an amplitude metric between the two horizontal lines. This is perhaps the only thing that's different on the portal from conventional EEG reading. Here, plus minus 50 microvolt means it goes from plus to minus 50 microvolt, means the space between the two horizontal lines is 100 microvolt. So what does it mean? Anything that is above 200 microvolt starts making me worried. Anything below, usually between 20 to 200 microvolts is allowed to some extent. So seizures are going to have higher energy because they are synchronized neuronal explosions. Therefore, they're going to have relatively higher amplitude. That's why you're seeing the shock wave or spike wave to depart from the baseline as much as it does. So be careful how you're reading it. So I'm going to show you an example. If the same EEG now is converted to plus minus 10 microvolt, you have jacked up the gain so much so that you're just kind of saturating the waveforms. This is exactly the same EEG as this one, but now the gain is 50, here is 10. So you have to be careful. I usually scale it to I don't know, Dr. Stern, what is your style of reading, but I usually scale it in such a way that it kind of takes about half of the space between the two horizontal lines, more or less. What is your style?
I agree. It's a matter of being able to see the detail. You don't want to blow it up too much, nor do you want to lose the detail. And it's nice to adjust it based on the patient.
Right. And some people have a thinner skull, and the amplitude recorded by electrodes will be higher to begin with. And that's fine. So amplitude, as Dr. Stern said, is not a big differentiating factor. What is important is the shape of the waveform. So you have to make sure that you are playing with the gain in such a way that you are differentiating the shape. Here, you're just blurring the shape so much so that everything is very confusing. Now, the high pass and low pass, what does it really mean? Well, high pass means you're letting the machine pass the signal higher than frequency. Low pass means you're asking the machine to basically show frequencies below that particular threshold. The default here is 1 hertz to 30 hertz. You can go to 70 hertz and even higher. It just means that you are going to be seeing, for the most part, waveforms between 1 hertz and 30 hertz. Notch filter is for the line noise. So that takes care of the 60 hertz noise. But if you have put the low pass filter at 30 hertz, it means you're asking the machine to kind of clean up everything that's above 30 hertz. So this notch filter may not be as active. And if you click it on or off, it may not change the shape of the EEG signal if your low pass filter is already doing it for you. Now, looking at these front electrodes, it's very important because you need to understand when the headband is set on the brain, basically electrode 1 and 6 will be in the front, right above the eyes. And when somebody blinks their eyes, you will see a potential generated. And don't mistake this for a seizure waveform, especially if it is basically has this shape of waveform that you are seeing. It is saturated here, so it doesn't go below the horizontal line, but it doesn't have the morphology of an epileptiform spike, as Dr. Stern was saying. Yes, you can have frontal spikes that will look very epileptiform and only in these channels. And you can also have intermittent rhythmic slowing that affects the front of the brain. But usually think about eye blink when you see activities like this. So eye blink usually happens in the front, usually 1 or maybe 2 of the electrodes. And they are isolated events when the patient is blinking. But if somebody is nervous or is having panic attack or having some problems and they go into an eye flutter, then you will see it in this manner. It is not a seizure because it doesn't have the morphology of a seizure waveform, and also it doesn't have the evolution and it doesn't actually last more than, and it's very similar to these single events that you are seeing throughout. And the patient is awake, you're seeing the posterior dominant rhythm. So that's the eye blink. Now, how does the muscle activity look like? Well, muscle activity will blacken the EEG. As Dr. Stan already showed you this type of pattern, the reason it's black is because there is high frequency and high power. What does that mean? Well, the muscle works with millivolt, brain works with microvolt. What it means is that the muscle is 1,000 times stronger than the brain activity. So no matter what, you're going to see myogenic, as we call it, myogenic activity on these electrodes. If somebody is tense, if somebody is having muscle contractions and so on, and you can actually see that. Now, this is 15 hertz. Be careful because when you're reading EEG with low pass of 15 hertz, you're basically converting all sorts of activity into these sharper looking spiky activity. So this is not a seizure. It is just because you have put the low pass at 15 hertz. If you go to 70 hertz, you'll see that this is a muscle artifact. It is black again because it has a very high power and very high frequency compared to the brain rhythm. Dr. Stan, any comments on how to differentiate myogenic from seizure?
I think the point to echo is being careful with the filtering, because it's so tempting to lower the filter to get rid of the noise, but then it actually makes it more difficult to read because this high frequency artifact will have low frequency components within it, and it's all you're going to see. And so if you go back to the filtered, the same artifact looks to be more in a normal EEG frequency range because you've eliminated the high frequency aspects. And that's, in my mind, more difficult to read. So
right.
Be careful with the filtering.
Movement artifact. So movement artifact is different than myogenic or muscle artifact. You see the muscle artifact when the electrode is nicely tucked in and is recording tension in the muscle in millivolt range. But movement is when either the head is moved or the electrode is moved, so that stability of the electrolyte milieu between the electrode and scalp is disturbed. And usually you see it in this way. So why is this a movement artifact? Well, think about this. This is at plus minus 50. Now I go to plus minus 100. Still it's saturating, even at 250, even at 500. So it means it's even larger than 1,000 microvolt, and that cannot be physiological. The brain doesn't generate in that amount energy. So it is it's a movement artifact. Either somebody has hit the electrode or the head is moving. Usually it has a very artificial waveform. It doesn't look like a brain physiological activity with smooth up and down. It is just perpendicular to the baseline, and it's going up in 1,000 to maybe 2,000 microvolt range. EKG artifact, unfortunately, we don't have EKG on Ceribell, not yet, and we don't have video, so sometimes it's difficult to see what type of artifact we're dealing with. But EKG artifact is easy to recognize, but it's also at the same time very sometimes tricky, because it may have the, if there is a slowing in the baseline, you have the slowing that the brain is generating, and then you have these sharp deflections that the EKG artifact is generating. It's basically every time the heart is beating, the blood is pumping through the carotid arteries, especially in patients with very thick neck or short neck, or the way that they are lying, you'll see this type of EKG artifact, and nothing specific to Ceribell. But because these are sharply contoured waveforms, if there is a slowing in on the baseline, it will look like Dr. Stern was saying, sharp waves followed by slow waves. Oh my God, this could be a pleptiform. The way to differentiate is that you see that actually, for the most part, it doesn't have that type of morphology. And Dr. Stern, any other way of recognizing EKG artifact without having EKG channel? Because if you had EKG channel, you will see that every time you see these on the red line, you see the EKG also going up and down like this.
I said earlier that one's looking for similarity of the wave shape or wave form as a way of picking out which is epileptiform. And I said also the shape has that EKG feature. So going with what I said before, this should be an example of something that's epileptiform. And in some ways it can be misseen as that. I think the timing of it being so precise is what makes it more likely to be EKG. And the occurrence across the entire recording. And of course, the interval being within intervals similar to EKG, 60 to 80 beats per minute.
Right.
So
if this happens,
I second guess it because of that high consistency.
Right. I mean, if you're recording this and you're seeing this on the portal, you may want to just call the nurse at the bedside and say, hey, can you register the pulse, or say what is exactly the pulse at that given moment? And then you will see if it coincides with the frequency of this artifact. So I think I've covered all of these. So now I would like to quiz you, Dr. Stern, on a couple of cases. These are real cases we have gotten permission to discuss. I have two cases, and then Dr. Pearl has one case that he would like to quiz you on, if that's okay.
Of course.
So one patient goes to an academic medical center in ambulance after a convulsive seizure. They have given a lot of benzodiazepines en route, and patient is altered and acting confused. What can it be?
So the question, of course, to any neurologist or ED physician is this altermentation because of a large tumor causing mass effect? Is it due to the fact the patient is still having a seizure? Or is it because the patient is recovering from a seizure? Or is this because of the benzodiazepines that were given as a sedative? And so you have four leading considerations upon presentation. Fortunately, we have a test that's really useful for differentiating across those four, and that's the EEG.
Okay.
Let's get an EEG.
Okay, got it. Now, case two, I'm going to show the EEGs in a second, and then we can review it. How about case two? What could this be? A 33-year-old man with history of epilepsy. He has primary generalized epilepsy, and he presents with altered mental status after binge drinking. He's in a community hospital emergency department, and wife basically argues with the emergency medicine doctor, who thinks this could be all about intoxication. Wife says that the husband is used to drinking this much, but never has exhibited this much altered mental state. This is not because of binge drinking. So what would you do and what this could be?
Well, of course, I'd want another EEG because the question is it alcohol or is it a matter of withdrawal from alcohol? Or is it a matter of seizures that are occurring because of the alcohol and lack of treatment for the epilepsy? In this case, there are two ways that the seizures could be occurring, but it doesn't matter how the seizures are occurring. The EEG is still going to be the useful test for determining whether they are occurring.
Okay, wonderful. So are you ready for seeing some EEGs?
Yes, please.
Okay, this is the first 15 seconds.
I see across the right side and posteriorly part of the left side, a recurring wave that has the same shape with each occurrence. It looks like a sharp and slow wave pattern. So it has epileptiform features and it's ongoing. And so it looks like a seizure in the sense that it's persistent and has the shape of a seizure. I see some evolution as it goes forward, where the shape becomes more clear. The sharp component stands out more. And here the frequency increases, that the waves become closer together in time. And these are additional features one expects for a seizure. At one point at the end there, it slows down, and that could be resolution. With status epilepticus, it can be that it's multiple seizures that are very close together without a clear behavioral change. And so it's possible for the EEG to show a resolution for the seizure that's brief, and then a return to the seizure without necessarily a behavioral change to the patient visible to you at the bedside. And so that might be what is occurring here. But depending on the duration, this looks like a focal seizure, and well, depending on the duration, whether it's status epilepticus or not.
What would you say? Do you think this is status?
So we typically define status as at least 5 minutes. And so
now I have 7 minutes, 30 seconds passed.
I'm sorry, 7 minutes, 30 seconds passed. Then
yeah, 8 minutes passed.
Yeah.
Yeah, this is a case where the fellow diagnosed at the bedside and asked for fosphenytoin. And now let's move forward. Do you want to comment on what happens to EEG after the treatment is given? I think around 19 minutes the treatment is in, and let's see how the EEG goes from seizure to non-seizure.
So on this page, I'm seeing on the right side 4, 5 clear epileptiform discharges, but between those discharges, it's just a suppressed background. The suppression can be because of the aftermath of the seizure, and the suppression isn't necessarily something ominous. Here I'm seeing some slowing, but also some recurrence of some of the spikes.
I'm sorry, I went back one page.
Okay.
Yeah. So here is kind of basically going what you're saying, repetitive, continuous pattern to something that is not as repetitive. And now you're seeing here. And do you think this is related to the patient's right temporal tumor? Don't know.
I think, of course, plausibly and reliably, yes.
And here there's some movement artifact. Do you want to comment on the EEG as I'm moving forward? Do you want to comment on the asymmetry between left and right?
So there's an amplitude asymmetry and there's a frequency. Well, it's hard, here's a point. It's hard to judge the frequency if you don't have the amplitude sufficiently turned up. And so the amplitude is greater on the left, it's suppressed on the right.
Right.
And all this can be related to the recovery from the seizure. Seizures end because of suppression of seizures, and this suppression through intrinsic pathways in the brain can suppress or does suppress normal activity as well. And so one expects some postictal slowing and suppression after a seizure.
Okay, in the interest of time, let me go to the next one. If Dr. Pearl can make his case ready for discussion. So this is the ED intoxication case. Again, this is a plus minus 50 microvolt. I'm not too happy with the way that the waves are displayed. I'm going to make it a little bit more orderly by going to plus minus 100, but I'm mindful that now, for example, some of these waveforms are about 200 microvolts strong. So I'm scrolling forward. Maybe I can do like this, and then you can give us your Gestalt impression.
Yeah, I see recurrence of a waveform shape that has that spike and slow wave contour. And it's predominantly anteriorly and it's bilateral. You see it clearly, or most clearly, in the 1, 2, and the 6, 7 channels, but the field falls off as one moves posteriorly on both sides. They occur sometimes, looks like 3 times within a second. It seems rarely that it's more than a second without. And so overall, they're recurring pretty quickly.
Right. So,
and this goes along with a high likelihood of status epilepticus, based on the duration and the persistence of the epileptiform wave, the frequency.
Right. So I had reviewed the EEG and had made some mark. Here's a very impressive one.
Yeah, here you're seeing it extend posteriorly really well. It's as much anterior as posterior. So the AP, anterior to posterior distribution, extends. And so one expects some variation within seizures. It's not going to be the same exact wave every single time. So another clinical pearl is that if something looks exactly the same with each occurrence, it may not be cerebrally generated. As being a pearl to accompany the one of, if you see it only in one location, one electrode, it may not be cerebrally generated. But
okay.
You're using variation, which makes it more plausibly cerebral.
Great. Okay, I will stop sharing. Dr. Pearl, I'm sorry we have gone over time. Is this an okay time for you to present your case? You are muted.
Yes, I'm here. Hi, Dr. Parvezi. How are you this morning?
Excellent. Do you mind telling our audience where you practice and what case you have? And you can now quiz Dr. Stern and myself. We haven't seen the EEG.
Sure. So my name's Harrison Pearl. I'm a neurologist in Mobile, Alabama. I did my training in Milwaukee, Wisconsin, and then a neurovascular fellowship at Emory and Grady Hospitals in Atlanta. And I'm from Mobile originally, so I moved back here. I'm the stroke director at Mobile Infirmary Medical Center, part of Infirmary Health. It's around 500 and change bed hospital, one of the largest medical centers in the region. And I do all of the stroke and a lot of the neurocritical care here. And hand in hand with that goes quite a lot of epilepsy as well. Working with both patients with chronic strokes and different types of brain injuries, we see quite a bit of epilepsy here. So whenever I came here 2 to 3 years ago, we had routine EEG with the neurodiagnostics department, but we did not have any form of continuous EEG monitoring. So whenever I heard about Ceribell, I was very, very interested in it. We've been using Ceribell for a little over a year now, and we've had very good results from it. Been very impressed by the technology. And since the implementation of the Clarity software, it has really become a powerful piece of technology for us that, not only allows us to treat our patients more effectively, but allows us to work in a smarter way, not necessarily a harder way, because it really gives us very accurate results very quickly that can be seen at the bedside by nursing, and they can apply treatment. And this case is an example of that. So this is actually a patient who I'm actively treating at this time. It's a 74-year-old man who came in several days ago. He had a syncopal episode and was confused, but was at least interactive in the emergency department. And then at some point after his admission, he had a VFib arrest. He was resuscitated and put into hypothermia protocol. He went through rewarming and was on propofol, but whenever they got to target temperature and they began to hold his sedation, he was not interacting with examiners at all. He'd briefly open his eyes and close them again, but nothing purposeful. He was not fixating or tracking, and he was flaccid in all of his extremities. He was very, very sick. He's hypotensive on 3 vasopressors. Due to his hypertension, he went into acute renal failure. So there's multiple different specialties helping manage this patient, and we were consulted due to him not waking or interacting from sedation. He had a CT head that didn't show any acute findings. He couldn't have an MRI because of his pacemaker. And so then we started the Ceribell, and nearly immediately it began alarming for seizures. The nurse called me and told me, I'm trying to move to the hospital and see quite a few different acute neurologic injuries. So it's very helpful that the Ceribell gives bedside results without me having to actually get on and look at the EEG. And the nurse can call me and tell me that there's something going on. So I said to give Ativan, and the Ativan stopped for a few moments the abnormalities we were seeing on the EEG, but then they quickly came back again. And so we gave fosphenytoin, and it improved again for several hours. But then, later it would recur. And if we can pull up the EEG.
Yeah, I can try to
show you how this has evolved and how the treatment has been applied.
Sharon sent me the link, Dr. Pearl. Let me do that.
Sure.
There we go. We won't have the clarity review on this yet, but we are just reviewing the EEG without.
So I would change the gain to 25 microvolts. But even here on the 50, you can still see the abnormal sharp waves, but here you can start to see them better. But essentially, yeah, you can see sharp waves across both hemispheres that are fairly synchronous. And they start, they'll spike with after going slow wave. I hate that we can't see the Clarity software here because it really provides a lot of visual information about how these build.
Right.
And that's one of the things for me about subclinical status epilepticus is how like you were talking about earlier, how it evolves. It's not like a clinical diagnosis of epilepsy where we just look at the pre-ictal, ictal, post-ictal phases and use the chronology and symptoms to make a diagnosis. Here we're purely using EEG because the patient is essentially comatose with no physical manifestation of any of this, no ventilator changes, no heart rate changes, nothing.
Right.
There you're seeing there's a burst of about 3 hertz. It's not clearly continuous, but it never goes away for any clear period of time. And then if you go check on the annotations.
I don't. Okay, lorazepam was given here.
Mm-hmm.
Okay, so let me go back from the time of lorazepam. Dr. Stern, do you want to take this?
Sure. I was just reflecting on pattern and Dr. Pearl's description of what he was seeing. One thing I would add is how there's fluctuation, that sometimes the discharges occur in close succession and stand out. There's a cleaner waveform. Sometimes they're gone. And there's no doubt about their epileptiform nature. One consideration in a patient like this, not necessarily this patient, is how much of this is reversible, how much of this is not. And that he had an arrest, but he also has reasons for encephalopathy that's metabolic. When I see discharges that vary like this and become very clean and very close together and then go away, I tend to orient myself toward being epileptic and reversible because of that fluctuation. In contrast, a person who has severe anoxic injury may have discharges that are less frequent, but also are much more regular. They don't change as much. And in some ways, the fluctuation of this shows normal ongoing brain activity. It's brain activity, manifesting the seizure, because you need to have some normal function for a seizure to occur, but also normal in the sense that it's suppressing the seizure.
Right.
So if we go to the first fosphenytoin dose, that's really where you see the background change, where it says fosphenytoin. There we go. So here, this is where it's starting to infuse. We still see a lot of these abnormal sharp waves with after going slow waves across both hemispheres occurring anywhere from up to 2 to 3 hertz, and then it'll dissipate for a few seconds and come back. And then as we go, after he was hypotensive, so this was very difficult to get him onto a significant dose of fosphenytoin safely, also with VFib arrest, with arrhythmia. But as we go on, all of a sudden, the background really, all these discharges nearly dissipate. And now we're into just more of a general slowing.
Right.
So just for me, just the response to treatment, the visual feedback that the Ceribell provides here is very useful in showing that this is an epileptic phenomenon that needs to be treated.
Yeah, really nice.
Right. No, this is really great. I mean, you're seeing some of these waveforms a little bit blunted, but clearly you got rid of that aggressive, these type of 2 to 3 hertz spiking wave, generalized periodic discharges. Yeah, this is
and a lot of these treatments, especially with this is still an ongoing EEG today, and the beauty of the Ceribell, at least for a private practicing neurologist, is that I can place orders in the chart saying if the EEG is flashing red, if the Ceribell is flashing red, reading continuous seizures, because I know that in this patient this is going to be fairly accurate, we can go ahead and apply treatments, PRN treatments that the nurses can do. So there were periods of time at 12:30 in the morning, 1:30 in the morning, when the EEG the Ceribell is going off reading red for continuous seizures, and the nurses give Ativan, and it shows complete cessation of the discharges. So we're able to provide the patient with treatment just based on nurse monitoring. And I think that gives a lot of fulfillment to the nurses at the bedside too, that become more involved with patient care. They feel like they are interpreting tests and applying treatment on their own. So I think it can really help in a lot of different ways for patient care.